Hi, everyone, and welcome to the Otolaryngologic Clinics podcast series. I'm Stacy Eastman, the managing editor for the series here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the June 2024 issue dedicated to sleep apnea in children and adults, guest edited by Dr. Stacy Eastman, Carol Lee, and Rita Danda Patil. Here now is our consulting editor, Dr. Sujana Chandrasekhar, to lead the discussion.
I'm Sujana Chandrasekhar. I'm the consulting editor of Otolaryngologic Clinics of North America. Today I'm speaking with the guest editors of the June 2024 issue of Clinics, which is on sleep apnea in children and adults. They are Dr. Stacy Eastman, who is an instructor in the Division of Otolaryngology, Head and Neck Surgery at the University of Wisconsin School of Medicine and Public Health in Madison, Wisconsin, in the United States. Dr. Carol Lee, who is assistant professor in the Division of Pediatric Otolaryngology in the Department of Otolaryngology, Head and Neck Surgery at Cincinnati Children's Hospital Medical Center at the University of Cincinnati College of Medicine in Cincinnati, Ohio, in the United States. And Dr. Rita Danda Patil, who is professor in the Department of Otolaryngology, Head and Neck Surgery at the University of Cincinnati College of Medicine and the chief of otolaryngology at the Cincinnati Veterans Administration Medical Center in Cincinnati, Ohio, in the United States. This is an excellent issue of Otolaryngologic Clinics of North America with 14 articles covering the breadth of this subject, and I encourage our listeners to read. But for this podcast, we will cover a few of the subjects. You can get all the podcasts, which is one for each issue of Clinics since 2017, at www.oto.theclinics.com or wherever you get your podcasts. And you can get individual articles and full issues at that same website or in your medical library. So first, let's meet our guest editors. Hello, Dr. Eastman.
Hi, thanks so much for having me.
Hello, Dr. Lee.
Hi, thanks for having me.
And hello, Dr. Danda Patil.
Hi, pleasure to be here with y'all.
So let's get started. Stacy, Dr. Eastman, it seems nowadays with the trend towards heightened interest in sleep, patients and clinicians may have a low threshold to determine if they or their patients, if they're the physician, have sleep apnea or another sleep disorder. How does this increased demand play into the usage of home sleep testing versus in-lab testing, and what are the pros and cons of each?
I would agree that there is absolutely a greater interest in sleep, and I love the fact that you pointed out that we as physicians are probably just as likely to have to look at ourselves as our patients. I do have more people that walk into my clinic or that I talk to at a soccer game about these kinds of issues quite often. I had a lovely conversation at the table with two of my in-laws about the Inspire. But I think that the home testing has made it so that everybody feels like sleep testing is more accessible and has really reduced the time it takes in order for us to be able to get some results. The in-lab polysomnography is still used for a subset of patients, but it's not the standard first-line therapy for adults anymore. And it is then more convenient to get a sleep test. It's lower cost. We have faster diagnoses. And honestly, for people with a high pretest probability, which is a fancy way to say highly likely to have sleep apnea, it is really useful to use home sleep testing. Now, it is a little limited in its data collection, and especially for women, I find it slightly less useful. And some of that's because women are more likely to have hypopneas, which is an event where they may have an arousal from sleep instead of a drop in oxygen, and these tests are not great at picking that up. It's the same reason we haven't validated them in children for the most part, although that's happening more and more frequently. And then if you have a normal sleep study at home, but you still have a high suspicion that you have sleep apnea, the in-lab polysomnography is absolutely the way to go. And it's also first-line therapy for us to think about complicated patients or those where they may have some other things going on like CHF, congestive heart failure. But it's higher cost, it's a little less comfortable, and it's definitely longer wait times.
So, when in-home studies started, Stacy, they were really considered very suboptimal, right? They were considered, better than nothing, but not really good. It was sort of the parent coming in with the tape recording of the child's sleep, perhaps. So what happened to make the in-home tests more reliable and something that you might rely on as a true diagnostic?
I think part of it was just seeing that if it was positive, it was useful. So there's some idea that it almost like the way we think about screening tests, and home oxygen is a great example. If you go home oximetry in kids, if it's positive, we believe it's true. But if it's negative, it doesn't have great negative predictive value. And I think we've come to realize that there's a great role for that, especially if it's easier, more convenient. It allows us to diagnose more patients. I also think there are some technologies that are probably better than they were when we first started doing them. And those may include things like tonometry and some other things that we've been looking at that we didn't have as the technology at the time when it was just an oxygen sensor and a respiratory channel.
So thank you. I have a follow-up question, and I'll pose this to Rena. So Dr. Danda Patil, what roles do polysomnography and home sleep testing have in determining outcomes after surgery, such as, even the hypoglossal nerve stimulator? Like, where do you use this? We know pre-op or pre-evaluation, but where do you use this after intervention?
Yeah, that's a great question, Sujana. So, obviously we've already talked a little bit about the preoperative use, and I think a lot of it depends on your own population that you're treating. So in my population where I treat veterans, they tend to be a fairly complicated group of patients with a very high rate of cardiorespiratory morbidity, sometimes insomnia issues that can make a home sleep test less accurate, and other sleep disorders. So I tend to lean toward getting a polysomnography in the lab because I really want to rule out central sleep apnea. Sometimes I have patients with chronic opioid use, and that can contribute to those issues. So in my practice, I tend to like the polysomnography more in the preoperative setting just because of the population I use. Now that might change postoperatively because you get to know your patients, right? I mean, you understand each individual really well. So if I've worked with a patient extensively to see if they're a good candidate for hypoglossal nerve stimulation, and then I operate on them and I'm working with them through all of the activation and all that, and I'm watching how they do with their usage. And we're talking frequently on the phone, we're looking at their data that is uploaded as to their usage, and we're seeing how they're adapting to the device. And that helps me decide if postoperatively I want to get a titration study in the lab, more formal polysomnography, where the technician will change the levels of the voltage of the device to see how it's working, versus doing something at home. So I have a number of patients who sleep quite well, and they have expressed to me that they did not enjoy being in the lab and they felt it disrupted their sleep. So in those patients, sometimes when I feel pretty comfortable that they're not having a lot of bouts of insomnia, which again can falsely lower your severity of sleep index on a home sleep test, then I often do get a home sleep test. And I have moved toward this, and many of my colleagues have moved away from the titration polysomnography after surgery, particularly hypoglossal nerve stimulation, which we're talking about, and move more toward a home sleep test because they feel like they're going to get a better result than using the titration, which is very variable between labs and technicians. So, it kind of depends on the patient, but I am leaning a little bit more toward home sleep testing to try to see how patients' outcomes are from an objective standpoint with the apnea-hypopnea index.
Very interesting. And like you said, I think this is a bit of individualized medicine, personalized healthcare, right? To see the one that you think would actually benefit from this rather than burdening the patient and the healthcare system with some unnecessary cost. I would like to talk about some other types of testing that everyone seems to be doing. So we talked about polysomnography, we talked about home sleep testing. Carol, Dr. Lee, let's say my patient has accomplished appropriate sleep study testing and it's clear that she can't tolerate positive airway pressure treatment despite working intensively with the sleep medicine experts. So she's very concerned about her health and she's now interested in surgical management of her obstructive sleep apnea. How would you approach DICE? And can you please explain how we do it in terms of decision making for possible surgical options?
Absolutely. So going along the theme of, patient specific or patient centered treatment, DICE or drug induced sleep endoscopy, which I'll call DICE for short, involves fiber optic endoscopy of the upper airway during spontaneous breathing while the patient is under sedation. And it allows us to identify sites of upper airway obstruction and potential surgical targets in patients who have obstructive sleep apnea but are intolerant or unwilling to use medical treatments like positive airway pressure. So with DICE, we can evaluate sites like the nasal cavities, the nasopharynx, the velum, the oral pharynx, the tongue base, and the larynx. And there are some great representative photos in the issue for reference. For adults, it's been shown that DICE can identify appropriate surgical options and avoid unnecessary surgery by identifying patient-specific sites of obstruction. You can use it as a separate procedure before considering additional surgery, such as in the case of hypoglossal nerve stimulation. DICE is used to determine candidacy based on the pattern and level of airway collapse. Alternatively, you can also use DICE during the same anesthetic period to determine in real time what surgical options are appropriate and then proceed with the surgery at the same time. For children, DICE can have multiple roles in the decision-making process. In surgically naive children, DICE can be useful to determine sites of obstruction when tonsils seem to be small on exam and you have a suspicion that there may be some other sites of obstruction. More commonly, DICE is used in the case of persistent sleep apnea after adenotonsillectomy as part of the workup for additional surgical targets. There's also some evidence that DICE can be useful in children who are surgically naive. They're undergoing a TNA or an adenotonsillectomy, but they're at high risk for persistent sleep apnea, and DICE can be used to identify some additional sources of obstruction to guide surgical planning and management for later on.
So, as somebody who has never done DICE, how do you prepare your anesthetic team, your operating room team, or your procedural team to keep the patient safe and get the information that you need? What kind of team preparation is there to make this successful and useful?
Well, I think that it definitely involves close communication and open communication with the anesthesia provider. Oftentimes, it's helpful to have a protocol established. So at our institution, we frequently use a combination of ketamine and dexmedetomidine. Other places use a continuous propofol infusion, and there's arguments and pros and cons to be made for either. The patient is often monitored, for cardiopulmonary complications of those medications. Sometimes in cases where the airway collapse is very severe, you have to, rescue the patient with jaw thrust or intermittently put on oxygen supplementation or even positive airway pressure in order to get the patient through. But it definitely involves some close collaboration with anesthesia to make it a safe procedure.
Dr. Ishman, would you like to opine a bit?
Yeah, so I have instituted drug-induced sleep endoscopy in a couple hospitals. And one of the most important things I think you need is an advocate on the anesthesia side. And it needs to be one of your braver colleagues. So if you're looking for somebody who is a little bit more of the cowboy, that's the one you want, because most anesthesiologists don't love the idea that we're going to let your oxygen level drop and do nothing. And in the midst of it, you need them to do some maneuvers and then stop doing them. And you need somebody who is willing to stop doing them. And so I will tell you that that's one of the keys, I think, to really instituting this is like everything Dr. Lee said, I completely agree with. But you also probably need the first few of these to be done by you without, help if you happen to have trainees or mid-level providers helping you so that you can prove to everybody that this is safe. And then also find your bravest anesthesia colleague.
Yeah, I think this is really important. We're looking at various ways that we communicate with our anesthesiologists for various aspects of otolaryngological procedures. at the American Otologic Society meeting in May, for example, we had an amazing presentation about cochlear implantation in the old elderly using dexmedetomidine, and the patient is awake during the procedure, and how well those patients do, and how that really expands access. But I think that the crucial point is what both of you were saying, that you really need that team to be prepared. And I think Dr. Ishman is right. You need an anesthesiologist who trusts you and trusts themselves so that the patient's outcome will be good. So Stacy, Dr. Ishman, let's keep with this concept and let's talk about Cine MRI. Is that a practical option for patients instead of DICE? And why might you choose that?
So Cine MRI is great because it's complementary to the drug-induced sleep endoscopy. It gives you a really fantastic view of interactions between the tongue and the palate, which I think are easier to see in terms of primary or secondary sites of collapse when you look on a Cine MRI. But realistically, most sites are not set up for it, and it takes, a significant amount of coordination. I can tell you, we instituted a program when I was at Cincinnati where we would do the drug-induced sleep endoscopy in the MRI induction room and then go straight into the CT scanner, the MRI scanner, and marry those. And it was great because you could get those as complementary single anesthetic evaluations. I think what's more common, though, is that people are doing drug-induced sleep endoscopy and sometimes doing additional surgery like nasal surgery or something that they can identify in the office. And so many patients are finding that that's sort of a better option. Sometimes it gets them to be able to use their CPAP, and you don't necessarily have to go on to a surgical option. And honestly, it's a lot easier to get and to get approved because most hospitals, the radiology department is not set up to do them. And I can tell you, again, I've set this up in 2 hospitals, and I had to sit in the MRI scanner for the first few at the one hospital, and then they would let me do it like in the hospital, but not in the scanner. And then, I had to be like in town, but my fellow had to be in the hospital. So it is not an area where people feel super comfortable, because if you think about what's required to deal with taking care of a patient in an MRI scanner, there's a lot of equipment where there's like a line going across the room that may not be immediately adjacent. Sometimes the anesthesiologist is not even standing next to the patient. And so there's much less level of comfort in initiating that program than even drug-induced sleep endoscopy.
I know, Dr. Ishman, you take care of children and adults, and I know that Dr. Dandapatil, you are primarily taking care of adults with this issue. Cine MRI, is it going to be something that we use? Is it going to be limited to really, detailed, centers of excellence, or can somebody in the community access this?
I actually had the same question for Dr. Ishman because she treats both populations and I only treat adults. When I was reading about this, and it was really well presented in the chapter, I've been treating sleep apnea surgically for pretty intensively for 10 years, and I have not really had any patients come to me having had Cine MRI. And from what I read, it seemed like it was mostly in pediatric hospitals. And so I was really curious as to your experience, if there are any adult centers that are doing this commonly, because I don't think it's very common in the adult population. So I'll kick that back to Dr. Ishman.
Yeah, so I would tell you, I know of a couple that have done it for research, and there's a few published series in adults, but it has not been widely adopted. And I think some of that is because we have some things like hypoglossal nerve stimulator and other treatments that seemed like they were effective without needing more of the soft tissue surgery. I actually think things are swinging back some these days. We realize the hypoglossal nerve stimulator doesn't work for everybody. And there is a real need for us to continue to do soft tissue surgery. So there is probably a subset where if it's not obvious with our regular evaluation, like drug-induced sleep endoscopy, they can really be additive. But I'll also tell you that after using the Cine MRI, I changed my drug-induced sleep endoscopy and do some more maneuvers to sort of figure out the primary secondary role of the tongue. So I think some of it, even on the research side, is going to benefit us whether we use the Cine MRI or just use it to improve our DICE.
I agree with everything that was said. I think that I will add one point, and in terms of Cine MRI for pediatric patients, agree with what Dr. Ishman said about the better view of primary and secondary airway collapse. The other advantage of the Cine MRI is that soft tissue resolution to look at the lymphoid tissue hypertrophy, and that becomes relevant, especially in pediatric populations populations, and more specialized populations like our kids with Down syndrome who have lingual tonsils as a common site of obstruction for persistent obstructive sleep apnea after tonsils and adenoids come out. It's not always obvious when you're looking at it with endoscopy how big the lingual tonsils are compared to how big the tongue is. And in that situation, cross-sectional imaging like MRI that offers you a view of how thick that tissue actually is really helpful.
So every time we think we got a handle on it, we don't, is what you're saying.
Pros and cons of everything.
Correct.
Yeah, this is why we tell people, if you want to get published, you should go into sleep medicine because we have a lot to learn.
So Rena, Dr. Danda Patil, going forward, you wrote a really nice article in this issue talking about comorbid insomnia and sleep apnea, which you refer to as COMISA, as like a single entity. There's a lot of discussion about how insomnia impacts treatment with dynamic therapies like positive airway pressure or hypoglossal nerve stimulation. And insomnia isn't something that otolaryngologists typically think about, except for like when a woman reaches a certain age, and apparently we are condemned to just being insomniacs at all times. But normally we're like, oh, that's not a real problem. The real problem is the sleep apnea. So why is it important to consider insomnia? And then how do you merge this idea of COMISA with your patients?
Okay, so Sujana, in our practice in our field of otolaryngology, we learn things in our residencies, and then we go out and practice, and then we learn from our patients. And that's how I feel like it's this lifelong journey of learning from our patients. So when I started doing hypoglossal stimulation, which is our surgical idea of dynamic therapy, right? We have the medical side of it is positive airway pressure therapy. And when we see patients in our clinic, in our surgical clinic, and we start talking to them, we realize that all of those things that the sleep medicine physicians and practitioners are asking about, we really have to start asking about, right? So it's not just what's your apnea-hypopnea index, what's your body mass index, what's your pattern of collapse on a sleep endoscopy. It's really about patient selection. And one of the big factors I've found in my practice and in my research too, is that insomnia is not something we've learned about. It's not something we really think about, except that we all have trouble sleeping now and then. But it's extremely important when we're talking about a patient-activated device, such as hypoglossal nerve stimulation. So that's why I started really looking into this. And when you search the literature, there's not much about it in the surgical literature, right? Because our previous therapies before hypoglossal stimulation were static therapies, right? We rearranged tissue in the pharynx and we let it heal, and then we saw what we got. But when you look into the medical side of things, the sleep medicine literature, there's an enormous amount of information about this entity of COMISA, which has been coined by many researchers in the sleep medicine field. And I think it's really important to recognize it. And I think that we have to teach it to our trainees. And I know I do that on a regular basis, is to find out what's going on with patients' sleep. Because if they can't sleep, then they can't use dynamic devices, right? If they're not sleeping, then those things don't work. And it seems obvious when you say it, but it isn't always obvious to patients until you point it out. So I really ask a lot of questions about sleep hygiene. How many hours they're sleeping? When are they falling asleep? How long are they awake? We routinely get the Epworth Sleepiness Scale, which is a very simple questionnaire that checks sleepiness, but we also get the Insomnia Severity Index, which is a simple questionnaire that we do in tandem with the Epworth. And it just takes a few minutes and we can get an idea of what the issues are with sleep. So then we have to talk to the patients about how do we address this? Because ultimately, if we're going to do hypoglossal nerve stimulation, we really have to think about improving their sleep hygiene so that it works for them. Because it's not just about reducing their severity of sleep apnea, it's about them being able to actually get usage out of it. And that's where we do a lot of cognitive behavioral therapy for insomnia, which we also call CBTI. And that's a non-medication method by which insomnia can be addressed preoperatively or postoperatively if it becomes uncovered after they have surgery. And we also can work with the patient's primary care providers and their mental health providers to talk about hypnotic therapy. There are lots of drugs that have come out in the last decade or two that are much better in terms of not causing respiratory suppression and other side effects compared to drugs in the past. And also, when the other things that I really delve into especially my population of veterans, is what are the comorbid mental health issues that often come along with insomnia? Because you think about it, depression, anxiety, PTSD, all of those, post-traumatic stress disorder, which I call PTSD, all of those can feed into poor sleep quality and actually may have sleep disturbances like insomnia as part of their diagnostic criteria. So I just think paying attention to this issue up front not only lets me counsel patients about reasonable expectations for outcomes after surgery, but it also helps the patients become educated about how their sleep patterns can play into usage of the device. And they become more invested in the process and are much more interested in doing these therapies, whether it's CBTI or taking sleep aid medications or doing therapy with their mental health providers. But it really helps us work together so that we can have success, which success, there's lots of definitions, but success should be that a patient can still use their device effectively. So that's the way I usually think about it.
And the questionnaires that you talked about, they're validated, but they're also translated into many languages where they have been validated, right? So I think when you have your World Sleep Society meetings, I think these are being used generally throughout the world to assess the patients. Is that correct?
Yes, these are very common. For example, the Insomnia Severity Index was actually developed by a French physician and has been translated into many languages. His name is Charles Morin. And so it's not that it started in the United States. It's definitely an internationally used questionnaire. And I think the Epworth Sleepiness Scale is also very much used throughout the world as well. And they're very simple and easy to administer, which is very helpful.
Stacy, Dr. Ishman, the first thing we tell everybody when they say, oh, my husband snores and maybe he stops breathing and, maybe this and maybe that, we're like, listen, just shove him over onto his side. Or they're already trying to push the noisy sleeper onto their side. So does it matter if they sleep on their back or their side or their stomach? And if it matters, what therapies work for this?
So the answer is it depends. There are some people where it makes a huge difference, and there's some where it really doesn't matter. But it makes sense that if you lay on your back and your tongue and the soft tissue falls back, that in fact you're more likely to have apnea. And that is, to some degree, the whole theory behind hypoglossal nerve stimulation, to help give you some additional tone and hold at least the tongue forward, and probably, honestly, gives a little bit of palatal tone too. But there's been a lot of great work, a lot of it by Dr. Ravaslut, who was so kind as to help collaborate on this chapter, which really talks about the importance of positional obstructive sleep apnea. And the definition is that when you lay on your back, you have many pauses, or the AHI or apnea-hypopnea index is double what it is when you are on your side. So if you're on your side or your stomach and it's half of what it is on your back, that's positional sleep apnea. And it can still be present on your side, but it just is significantly less. And so this tends to be more common in women. We also see it reasonably in men, women, children, it could be anybody. And there are the old traditional techniques. We were all taught to put a tennis ball in your shirt. I can tell you that lasts for a good day or two before people stop wearing that shirt. I will also tell you that there's a pillow that's FDA approved for you to actually sleep on your back, or not sleep on your back, but it is a ridiculously expensive pillow that you have to write a prescription for. So we don't use it that much. And then what's more interesting now is there's these vibro-tactile devices, which is a super fancy way to say there's something that vibrates when you lay on your back. It has a sensor, it can figure out when you're laying on your back, and there's one that goes around your chest, so there's a different brand that goes around your neck. And it kind of progressively increases the amount of vibration until you turn over on your side. And the goal is to make you turn over on your side without you formally waking up. And those have some studies that look like they're fairly reasonable in terms of their ability to do this. I think they're more commonly approved, quite honestly, in Europe right now than in the US. I haven't had a lot of approvals. I don't know if Dr. Donda or Dr. Lee's had any different experience, but most of my patients have to buy them out of pocket. And it's the reason we haven't heard about them much in the US, because they aren't currently covered.
Yeah, I would just comment that I agree that these are not readily available unless you pay out of pocket. And in my practice, we use one of the pillows, like you described, it's a side sleeping pillow. And it's really the problem with all these positional device, these bulky things that try to force people onto their side, is that they're not really patients are not compliant, is what I guess I'm trying to say in general. They may be compliant for a short period of time, but if you think about it, people want to sleep, they want to sleep the way they want to sleep, and they're going to turn over onto their back without knowing it. And so sometimes if there's something blocking that, they're just going to remove it. And so naturally, I think that we've had lower compliance with those types of devices. But I am very excited for the vibrotactile. I'm looking into it now in my practice to see how we can bring it in. But I don't see that commonly. I don't see patients coming in and even asking about it. I think it's a little bit of an unexplored area, at least in our country.
So just going back to the way we started this conversation, where we talked about home sleep studies, do you ask the patient to sleep on their back and then sleep on their side, or did you sleep on your side? Is there any way to look for positional obstructive sleep apnea on the initial, I'm going to say screening study, even though it's diagnostic?
So I would say that we do tell them to lay on their back. That doesn't mean they do it, but hopefully they at least start that way. And if they have a bed partner who's with them or who will be paying attention to the instructions, we do also tell them to try and encourage them to lay on their back. Dr. Danda, what do you do?
I was just going to mention that when I look at the sort of screening or the preoperative formal in-lab diagnostic sleep study, the polysomnogram, in most studies will show you how much time they spent on their side, how much time they were on their back. And it'll also give you a supine apnea-hypopnea index and a non-supine. So I often look at that as a sort of a guess to get me a guesstimate of what they're doing at home. And then I ask them, and often I ask the bed partner because that's the most reliable person who will tell me, oh, they start off on their side, but within half an hour they're on their back for the rest of the night. And that helps me kind of gives me a feeling of an idea of how much the sleep studies are reflecting what's happening in real life. And then when they do go, for post-operative sleep studies, let's say, we try to get them to sleep in the most optimal position to see how the device is working. I'm not sure if that answered the question, but that's kind of how I approach the position when I'm looking at the data.
All my patients complain about it in the sleep lab.
And that's because you want the worst, you want the patient at the possibly worst, correct?
In an ideal world, you want to see what it's really like at home, right? So there's some pro con about whether it's making them sleep on the back if that's not what they really do. But I can tell you, I have patients who tell me they never sleep on their back and half their sleep studies on their back, not because a tech turned them over in their bed. So I think we want a realistic idea of whether or not at least some of the night is done on your back. So we can figure out if in the most likely position where you're going to have sleep apnea if it occurs.
And Carol, Dr. Lee, any advice you give to the parents of children in terms of side sleeping, back sleeping, stomach sleeping?
We definitely, in certain situations, do utilize positional therapies. I think that we, just like in adults, use the initial diagnostic polysomnogram to guide us. And if we see that there are way worse events or only events in supine position, then we can consider positional therapies like pillows and vibrotactile devices to help with that. The other thing that we can sometimes do, is we obtain a specific, positional sleep study with either the head of the bed elevated or lying on their side to see and to confirm that positional therapy is actually effective.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
I'm Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America, and today I'm speaking with the guest editors of the June 2024 issue of Clinics, which is on sleep apnea in children and adults. I'm speaking with Dr. Stacy Ishman, Dr. Carol Lee, and Dr. Reena Dhanda Patil. You can access individual articles and full issues of Otolaryngologic Clinics of North America at www.oto.theclinics.com, and hopefully also in your institutional and personal libraries. And you can listen to all of the podcasts. We have been recording one per issue since 2017 at the clinic's website or wherever you get your podcasts. As always, if you have any suggestions for topics or for how to improve clinics or the podcast, please reach out to us. So let's continue this conversation. Let's talk a bit more about neurostimulation for sleep apnea. So Reena, Dr. Dhanda Patil, hypoglossal nerve stimulation, or HGNS, has been around for about a decade now. So it's not a novel therapy anymore. What are your thoughts about the current state of I'm going to use a trade name here for the United States. Inspire is currently the only FDA-approved hypoglossal nerve stimulator in the United States. But what are your thoughts about that in terms of success? And you did say that we have to talk about what is the definition of success and how the surgical procedure and its indications have changed over time.
Okay, well, it's a big topic. I'm going to try to boil it down to a few points. I think that we in sleep surgery, those of us that try to treat sleep issues, with surgical procedures, we would love to have a one-size-fits-all procedure, right? I mean, I think we all tried to do that with uvular palatal pharyngoplasty or UPPP that was introduced in the 80s to this country by Dr. Fujita from Japan, and we were disillusioned with it over time because it was not done in a tailored fashion and people didn't have great results. And also it's not the most pleasant surgery to undergo, so it was not viewed very favorably by many people. And then we've come up with this dynamic therapy that is very exciting in that it works with patients' inspiration to help open the airway with each breath. Now, I think the main thing that I always tell patients is there's no magic button, there's no magic therapy that's going to, treat sleep apnea perfectly well in every patient. It's such an individualized problem. And what we've seen over the last decade is as the studies are coming out, depending on how we define success, a lot of times we define it according to Scher criteria, which basically means that the apnea-hypopnea index comes down by 50% or less than 20 as an absolute number. And sometimes it's more strict with the criteria requiring it to come down below 15. But in any case, we're really only seeing about a 60, sometimes 70% chance of success according to those criteria. I think the difference is that we are seeing a lot of patients who are very subjectively satisfied with this procedure, and they have good adherence, but we're not always able to prove sort of objective success with reduction in the apnea-hypopnea index. And this could be related to the fact that many of these patients really, really didn't like using positive airway pressure. It was very difficult for them. So they're happy with really any therapy that comes along that is not PAP. And also, we having a lot of conversations within sleep medicine and sleep surgery fields about what are the ideal measures to really decide if a patient is having a good outcome or good success. We've always focused on this apnea-hypopnea index, which is such a one number. It's a snapshot in time. It doesn't always relay how patients are feeling, how they're using the device, their comfort, all of those other factors. So there's a lot of work being done on this. I think there are a lot of investigators in the sleep medicine field that are looking at more like things like cardiovascular morbidity or hypoxic burden. So I think we're going to be hearing a lot more about that. So I always tell my patients it's not a magic button. We have to do a really good job with selection up front to make sure that we're picking patients who we think are really going to benefit. And so I know I'm very particular about who I agree to implant. And I know that most of my colleagues who do this and who actually follow the patients, if you follow the patients after surgery as I do, you're a lot more picky because you see what happens with patients if they're not using the device or they're not able to because of a variety of comorbidities. So I think that's kind of my general take on sort of success idea. In terms of, there have been some hardware changes. I think they've made the surgical procedure easier and quicker in terms of utilizing 2 incisions rather than the initial 3 incisions. And there have been improvements in some of the engineering of the sense lead, which was having issues with breakdown. So that, I think from a mechanical standpoint, we're progressing. I also just would like to very briefly mention that FDA Federal Drug Administration guidelines in the United States have expanded. And this has led to some controversy because there's more openness to doing the procedure for patients with a very high body mass index, up to 40. It's invited a lot of discussion, and a lot of us in the field believe that while it may be helpful for some patients with high BMI, we also really need to work on our outcomes just in our lower BMI population, because we have a lot of challenges as it is. So a lot of the research that we see is industry-based, and so it really helps to keep on working on independent studies to try to evaluate these latest indication changes. And then the last thing I would say is that there are new devices coming. I think the Inspire device, it was a first mover, and it's been the only FDA-approved device in our country for the last decade. And I know this is not the case in Europe and other countries. There are openness to other devices, but we will be seeing a lot more competition and a lot more devices coming on the market. I think in this country, we will probably be seeing the Genio device by Nyxoah coming out. It's more minimalistic, and it works by bilateral hypoglossal nerve stimulation. And there's also some other devices, for example, LivaNova is another company that's developing a device that's more non-specific stimulation. There are investigators that are working on ansa cervicalis stimulation. So there's a lot of work going on in this area that I think we're going to start to see some changes.
There's a lot of overlap between obesity management and obstructive sleep apnea management. And you talked specifically about higher body mass index patients. And I know that there's been quite a bit written about either surgical or medical weight loss that assists or is complementary to the management of sleep apnea. So where do you counsel your patients, Dr. Dandapatil, in terms of how they should lose weight, when in their weight loss journey these interventions that you can do for their sleep apnea would be the most beneficial?
Yeah, so weight loss is always something we're working on. And just to give you an idea, my average patient comes in with a BMI of 33 to 34, sometimes 35. And I think a lot of times weight loss is very difficult to do. It's difficult to sustain. And so we don't want crash diets. I don't want patients, just jumping on a medication to lose weight drastically so that they can then come in and have the surgery, because they're very prone to gaining that weight back. So I am quite wary of sudden weight changes, but I do talk to my patients about that sustained weight loss and healthier habits and lifestyles and things like that to see if they can get into a good range. And I also think it just shows a lot of motivation on the patient's part, because it's so difficult to lose weight. And if they do it in a sustained fashion, then I have a pretty good indication of their motivation to have a device placed. And I thought it would be interesting to hear what Dr. Ishman has, if in your experience, if you're seeing a lot of patients come in who have been taking, semaglutides and other medications, and then trying to become a candidate for something like hypoglossal nerve stimulation.
I've definitely had patients where I even encourage that. And some of the reason for that isn't just for the sleep apnea. I think we all know that treating obesity helps in so many other ways. And that's usually the conversation I have. It's not a good idea to take a medication just to meet the criteria for hypoglossal nerve stimulation if you're just going to stop after that. But it is also hard to be motivated to work out and do things when you're really tired from sleep apnea. And so this may, in fact, be a way to get you where you need to go. And quite honestly, GLP-1s may make it so you don't need any kind of intervention from me. You might be able to get to the point where you can tolerate your CPAP, or you don't need CPAP, or a dental device will work. And so those are really nice conversations to be able to have when you think this is probably good for the whole human and not just for the sleep apnea.
And I think I'm going to also ask Dr. Lee. So Carol, obesity in children is a real issue in the developed world. So where are you when you counsel these patients and their families regarding weight and where your intervention fits on the spectrum of their healthcare?
Yeah, I think part of a really common thing that I say to parents and caregivers of children who are obese when we're talking about options for treatment of sleep apnea, when we're talking about surgery, is that obesity tends to be a risk factor for increased severity of sleep apnea to begin with. It tends to be a risk factor for persistent sleep apnea after we take out the tonsils and adenoids. And so that's something that I make sure that parents and families understand right off the bat. In our children who have persistent sleep apnea following tonsils and adenoid removal, we often approach them in a multidisciplinary fashion. And we often have them meet and work with nutritionists, dietitians, to help with the weight piece. The other, kind of strategies that we not often refer patients towards, but, if it's appropriate, we actually, have had patients undergo bariatric surgery. There are, older kids who are on the, Ozempic and Mounjaro and other kind of semaglutide medications. And, regardless of kind of the avenue by which they lose the weight, we do know that with weight reduction comes added benefits of not only, metabolic benefits, but also reduction in sleep apnea severity. And they not only become candidates for additional surgery, but they might actually not need additional surgery or other medical treatments if they do lose the weight.
Earlier in our conversation, Dr. Ishman, you talked about some differences between men and women in terms of sleep studies and obstructive sleep apnea presentation. So can you talk to us about some sex differences and how we take that into account in our patients when we're seeing them?
Yeah, I actually love this question because I don't think we talk about it enough. We know that sleep studies look different for women. In fact, they are more likely to have partial obstruction or hypopneas instead of a complete stop of breathing like an apnea. And so they're less likely for the family member to pick that up. Or the bed partner. They're also more likely to talk about insomnia or fatigue or depression or headaches, which are not the signs that we always associate with classic loud snoring, witnessed apneas, which are more commonly seen in men. And so I think it's significantly underdiagnosed. I will also tell you that we are not quite as likely to give them the same treatment effectiveness. So women may respond differently to some of these treatments because they're probably underrepresented in most of the initial trials. Absolutely in the initial CPAP trials, because more men who are in the sort of age when you're premenopausal, not that men are menopausal, just to be clear out there, but in the age under, 45 or 50, it's a significant predominance of men. And as you get older, women are more likely to have sleep apnea. And so most of those trials were done on men. And as we start looking at these things, there's probably anatomic differences, there's probably hormonal differences. And there's one group, especially pregnant women, who we know have all kinds of fluid shifts and things that happen that make it much more likely that they're going to have some sleep apnea, maybe even just during pregnancy, or that starts at the time of pregnancy. And it's not really on the list. I can tell you, I was never taught to ask a pregnant woman about snoring when I went through my OB/GYN rotation as a medical student.
Rena, I know that at the VA, the majority of your patients are men, but there is a significant, large subset of women veterans. And do you notice that in that kind of group as well?
Yes, one of the things I have noticed is that I do get some women coming in. They do tend to be a little bit older. All of the women that I've operated on in the last, few years have been 55 to 60 or older. I'm not operating on younger women. So I think it's very correct that we don't see this really coming to light or becoming more obvious until women go through menopause. I think that the way that the women I've treated carry their weight also makes a big difference in their response to treatment. I think that we're learning that central obesity that we see more typically in men is going to be more associated with airway collapsibility, whereas women can carry more weight and have a more stable airway and not have the same kind of issues with collapsibility, and that they tend to have less severe OSA at the same BMI, let's say. And I've also noticed that the women in my practice that I've done hypoglossal stimulation on, they've had very good results. They've had a lot of success in terms of usage, comfort, and overall results. And I know that's been noted in some evidence in some of the trials that have looked at the large registry of hypoglossal nerve stimulation patients through the ADHERE registry, we've seen that women have generally had better results in response to this therapy than men, although this is, again, a small set of data and not necessarily validated over and over again. But I think we're starting to see that. And I know I see that anecdotally. I'm not sure if perhaps Dr. Ishman sees that as well.
Yeah, I also think, and you probably do see this, Rena, that positional therapy is probably more effective in women with mild sleep apnea. And so we just talked about positional therapy. This is a group especially where it could be really useful. And then there are probably also some signs that women who lose weight are not as successful at getting completely rid of their sleep apnea as men who lose weight, probably some hormonal component, which again, we haven't really studied.
Yeah, I mean, I think it's really interesting, and it's one of the take-home points for our listeners, I think, as a non-sleep apnea specialist, is the difference in presentation. Just like heart attacks present differently in women, I think when a woman comes in and she's telling you that she's fatigued and she's depressed and she wakes up in the morning with a headache and so on and so forth, I think rather than dismiss her concerns, I think we have validated instruments that we can give to them, and we can say, listen, can you just complete this so I can get a sense of whether this is early depression, whether this is hypothyroidism, whether this is sleep apnea or sleep apnea with insomnia. And I think being cognizant that we do not present as women at the same decade and with the same symptoms as we have classically considered sleep apnea presentations is really important. So now that we've talked about grown-ups, let's talk about infants. I think, when I was in training, I was thinking about this when I was reading this issue of Clinics. The person who taught me the importance of identifying sleep apnea in very young children and in infants was actually a very forward-thinking pediatric cardiologist at NYU who really bridged that gap that Stacy was talking about, that sleep apnea and obesity and other things affect the entire patient. So she was a cardiologist who actually brought the message to otolaryngology that we need to be looking for this. And I think that cross-specialty communication is really important. So what, Carol, are the unique considerations for evaluating and managing sleep apnea in infants?
This is definitely a unique population when it comes to managing sleep apnea. Just like we were talking about for women, symptoms can be different in the infant population in newborns compared to older kids and adults. Snoring is less reliable in this age group as an indicator of obstructive sleep apnea. More often, caregivers can report witnessed apneas or pauses in the breathing. There can be a history of brief respiratory unexplained events or BRUIs. You can find that, parents can complain that their babies are restless. They don't seem to be able to fall asleep easily or stay asleep. They may be waking up very often. And you can see generalized symptoms like failure to thrive. And so for this reason, we do recommend having a high index of suspicion for sleep apnea in infants who have known risk factors like prematurity, neuromuscular disorders, and craniofacial anomalies. There's a really complete list of comorbidities that's associated with sleep apnea that can be found in the issue for those who are interested. Now, in terms of evaluating for obstructive sleep apnea, if you have that suspicion, diagnostic polysomnography, just like in adults, is the gold standard. But if sleep lab resources are limited, and we have had patients who, for whatever reason, they don't live close to a sleep lab, their insurance is not going to cover it, we have to come up with some other solutions. And home overnight pulse oximetry is a useful screening tool, and it does demonstrate a high sensitivity and positive predictive value for obstructive sleep apnea. In terms of diagnosing, when you're looking at the report for the sleep study, we still use the standard pediatric cutoffs to classify obstructive sleep apnea. But those are used for, 12 and 13-year-olds, and we're also applying them to newborns. And you can imagine there are some distinct differences between infants and older children. Infants have increased upper airway and chest wall compliance. They have more ventilatory instability, with an increased tendency towards central apneas. From a sleep stage standpoint, infants spend more time in rapid eye movement sleep, and they have less consolidated nighttime sleep in general. And so, all of this is to say that polysomnography data, even in healthy neonates and infants, can sometimes show higher respiratory indices. And, you have to take it with a grain of salt that you're applying these generalized normative data to a very specific and special population. To talk a little bit about management, say you've diagnosed sleep apnea in the infant, what are the most likely causes? Unlike in the older kids, tonsil hypertrophy is much less common in newborns and infants. The causes of sleep apnea are often multifactorial, and there's often a combination of immature breathing control, there's neuromuscular hypotonia, and there's a lot of different anatomic contributions, depending on whatever their, underlying syndrome or diagnosis is. From an anatomy standpoint, to talk about, different parts of the anatomy, since we're surgeons and we all like to talk about surgery, nasal obstruction can be a huge issue. Most commonly, it's neonatal rhinitis, which is something that will ultimately get better with time, and we often treat conservatively with topical medications. Rarely, piriform aperture stenosis or choanal atresia are causes of significant nasal obstruction, and they should be on your differential when you're evaluating newborns or infants with significant nasal blockage. Talking about other causes, micrognathia is a big one in this population. There are several different syndromes and sequences, Pierre-Robin sequence, Stickler syndrome, that can result in micrognathia or retrognathia, which then leads to tongue-based collapse and resulting upper airway collapse that can cause a range of different sleep apnea severities. In the milder cases, we tried to temporize the babies with supplemental oxygen, stenting. In the more severe cases, we consider mandibular distraction as an option to treat sleep apnea and to avoid tracheostomy. There's a lot of other causes. In the interest of time, I'll talk about one more, which would be laryngomalacia. We always think about it as the most common cause of noisy breathing and stridor in infants, but it's also a common cause of obstructive sleep apnea. Classically, we think of laryngomalacia as that congenital variant, which is squeaky, noisy breathing that's, intermittent, but always during the day. It's during feeding, it's during agitation. There's a variant of laryngomalacia, sleep-dependent laryngomalacia, that exists when you only have symptoms of stridor and obstruction during sleep. So in this context, sleep endoscopy is useful for diagnosis. And you think about treatment, kind of on a range of severity. In the milder cases, sometimes you can temporize, wait for the baby to grow. You can treat with supplemental oxygen. And then in the more severe cases, consider supraglottoplasty in that instance as well. Compared to older populations, infants and newborns are definitely a unique population. They have their own set of etiologies for sleep apnea, and it's often related to underlying genetic conditions and congenital anomalies. There's a whole range of medical and surgical options for management. And so for this reason, we oftentimes approach this in a multidisciplinary setting.
And just to get back to positional changes, infants are able to be put into whatever position and stay there, at least for a few months. So what would you recommend for the various, maybe a laryngomalacia situation that is causing the sleep issue?
So in general, we still follow safe sleep guidelines, and we, still recommend for infants and newborns to be placed on their back for sleeping. The the issue with prone positioning, which might be helpful in terms of helping the airway not collapse as much, is that it does increase your risk for SIDS or sudden infant death syndrome. And so, we don't oftentimes deviate too much from that recommendation for, safe sleep on the back. But, sometimes in very specialized cases, when you have a bad case of micronathia, a bad case of glossoptosis, you can consider stenting and then, monitored prone positioning as well.
Thank you. So we're coming towards the end of our time, and I cannot believe that we have spent all this time talking about sleep apnea in children and adults, and we are finally getting to tonsillectomy and adenoidectomy. That will tell everyone in a nutshell how far this field has come from even when I started my training, and that wasn't that long ago. I mean, I'm old, but I'm not that old. Dr. Ishman, so Stacy, what are the short and long-term benefits of adenotonsillectomy for pediatric patients with both sleep disordered breathing and obstructive sleep apnea? And what are the risks? What are you counseling parents, and what are you and the pediatrician talking about?
I think we've learned a lot. We finally have randomized controlled trials of tonsillectomy in a couple different settings now and in a couple different countries in kids in a number of different ages. So that's great. And that's given us a little bit more. So we had some understanding of some of the outcomes, and those include things like sleep quality, the symptoms we see. The kids are cranky in the morning, the school performance isn't as good. There's some good studies, even that, if you just get more sleep, you're going to have less motor vehicle accidents in teenagers. Treating sleep apnea, we know in kids, is important. I will also say that some of the short-term benefits include things like sleeping through the night in younger children, and absolutely daytime behavior. And that's one of the big differences in kids, is that many of them will present with what looks like hyperactive behavior or focus and attention issues, when in fact, that's how they're presenting with sleep apnea. So we talked about the traditional version. And when we think about the traditional idea of what sleep apnea looks like, it's just what men have. It's not necessarily what kids have. I think Dr. Lee made a great point. We published a study that half the infants we saw with Pierre Robin didn't even snore. So it's not the best thing to pick up. And I'm going to be honest, if my kids are asleep, I am not going in there to see what's happening. I'm just ecstatic that they're not awake. So I don't think our understanding of what kids are doing during sleep, if we're in a privileged setting and we don't have to sleep next to them or in the same bed or in the same car, is always as illustrative as it is if you have somebody sleeping in the same bed with you, as many adults do. And so it's also sort of a little bit unknown because kids have most of their symptoms in the last half of the night, which we are hopefully really asleep for, unless we're getting up early for work. So there's a lot of data saying that there's probably some neurocognitive function issues. There's been a few randomized controlled trials that say that maybe that the differences in neurocognition by having sleep apnea and having it treated aren't as big as we thought they were in the past. And that development, maybe is overcoming some of that for some of these kids. But there is some baseline data that kids who snore don't do as well as kids who don't. And there is some long-term data, especially in the latest trial, which is the pediatric adenotonsillectomy trial, which is a randomized control study, that did show some differences in nighttime blood pressure control. And so the concern is this making it more likely that you're going to have long-term into adulthood blood pressure issues with untreated sleep apnea? Now, the good news is in otherwise healthy kids, 80% of them really get better with adenotonsillectomy, and that is great. Unfortunately, when I trained, which again wasn't that long ago, we thought everybody got better. So it's good that we have an understanding that not everybody does. And if you're obese or you have syndromic status, or especially if you have trisomy 21, it's more likely that you're not completely resolving. And so we've probably figured out better who to take a better look at afterwards to see if you have persistent disease, regardless of snoring symptoms, but especially if you have snoring or daytime problems, or back to those behavioral issues we talked about before. Now, the other thing you talked about was risks. We commonly talk about the risk of bleeding. It happens in about 3% of kids if you talk about who comes back to the hospital, or 1% if you talk about who goes back to the operating room. There's also a risk of infection, although very uncommon. We talk about airway obstruction, especially in the immediate post-op period, although again, pretty rare. There's post-op, pulmonary complications can occur more commonly in younger kids or syndromic kids, so we keep them in the hospital more likely than other kids. At least that's what our guidelines recommend. And then we also talk about dehydration. So that's actually the most common reason in most studies why kids come back to the hospitals. They're just not drinking enough. And I think as we get better at figuring out how to take care of pain afterwards, we're doing a better job. So the addition of steroids to the post-op regimen, I think, has reduced the number of kids who come back and the number of kids who make phone calls, or their parents, let's be honest. And the reduction in opioids means we're less likely to see things like constipation, and not that much more likely to get phone calls about pain now that we've added the steroids and added ibuprofen to the mix for most of those patients. So in terms of inpatient and outpatient monitoring, I don't know that we need to get super in the weeds about that, but there are some guidelines both from our American Academy of Otolaryngology and from the pediatricians, as well as sleep medicine. And really the thought is if you have severe sleep apnea, kids who are obese and those who are young, under 2, and then honestly the syndromic kids, those are the most likely to keep, or anybody who looks bad in the PACU after a couple of hours.
Thank you very much. This has been a really wonderful discussion. I thought I knew a lot having read the issue, and then I just learned more. So I always love recording these podcasts. I'm going to give you guys a chance for sort of a final little, maybe 2-sentence pearl. So let's start with in order of guest editorship. So Dr. Stacy Ishman.
So one of the chapters we didn't get to talk about was about social determinants of health. And one of the things I think is the biggest area for us to investigate is how commonly are we under-identifying these? What's the correlation with some of the socioeconomic status, race, and ethnicity? And I think that's something for us to keep in mind as we look at these patients is, are we underdiagnosing it? Are we diagnosing it later in kids who are non-white than those who are white? And so same thing in some of the adults, it's much less likely to be diagnosed at a younger age, even adults who may have normalized it, but also we just may not be looking for it. So that was a paragraph instead of 2 sentences, but thank you.
Thank you. I think that was a very important paragraph, so I will allow it. Dr. Lee, Carol, what say you?
I guess my pearl would be that, children and especially infants are a very unique population when it comes to sleep apnea. It's probably said too much, but, children are not little adults and we have to treat them differently. And that applies to sleep apnea as well. One of the things we didn't get to mention too much about is, how does one approach persistent obstructive sleep apnea after the tonsils and adenoids are removed? And I think this is a really fascinating topic, and there's a lot of good research surrounding it, research to be done, and there's more information about it in the issue. One thing that I will say about that is there's a great role for drug-induced sleep endoscopy as well as an MRI in that patient population. There's a variety of surgeries apart from tonsils and adenoids that are available for children, and there's more and more innovation in that realm every day.
Thank you very much. And last but not least, Dr. Reena Dandapatil.
Well, my pearl is just to really look at every patient holistically and individually, because we are all so different and our sleep disorders are very different from patient to patient. And so I think really working on getting a really thorough sleep history and looking at comorbidities that we're not necessarily accustomed to focusing on as otolaryngologists will really help our surgical outcomes down the line.
Thank you very much. I'm Sujana Chandrasekhar. I'm consulting editor for Otolaryngologic Clinics of North America. And today I have had the great pleasure of speaking with the 3 guest editors of the June 2024 issue of Clinics, which is on sleep apnea in children and adults. I've been speaking with Dr. Stacy Ishman, who is an instructor in the Division of Otolaryngology Head and Neck Surgery at the University of Wisconsin School of Medicine and Public Health in Madison, Wisconsin. I've been speaking with Dr. Carol Lee, who is assistant professor in the Division of Pediatric Otolaryngology in the Department of Otolaryngology Head and Neck Surgery at Cincinnati Children's Hospital Medical Center, which is part of the University of Cincinnati College of Medicine in Cincinnati, Ohio. And I've been speaking with Dr. Reena Dandapatil, who is professor in the Department of Otolaryngology Head and Neck Surgery at the University of Cincinnati College of Medicine and chief of otolaryngology at the Cincinnati Veterans Administration Medical Center in Cincinnati, Ohio. You can access all of the issues and individual articles, as well as all of our podcasts at www.oto.theclinics.com. sleep.com. I hope that your medical library subscribes and you too can subscribe. Thank you so much to my guests, and thank you so much to our listeners for making this series so successful.